It's my pleasure to introduce one of the first emergency physicians of Kerala. His name is Dr. Ashish Salim. His degree is MD Emergency Medicine, DNB Emergency Medicine, MRCEM, and also FACEE in Pediatrics. It's a pleasure to be working with him and knowing him since more than 8 years now. He's been working as the Deputy Chief of Emergency Department and also the Clinical Safety Officer at PRS Hospitals, Trivandrum. And he's also the Secretary for the Society for Emergency Medicine India, Kerala chapter, and also the Secretary for the IMA Kovalam branch. So he will be talking about today on the pediatric non-accidental injuries. It's one of the important topics because as emergency physicians, we almost see about 10 to 12% of pediatric age group people in the emergency departments. And many a times we will not be getting the history saying that it is a trauma. And not all traumas will be the injuries which happens. So some of the injuries which happen and come to the emergencies are also non-accidental injuries. So Dr. Ashish will be explaining us in detail about those injuries and what we are supposed to do in emergency department. Thank you very much, Ashish, for accepting our invitation and joining us with the forum and sharing your knowledge. You can start.
Thank you, sir, for the invitation. Thank you, sir, for the warm welcome. Good evening, all. So today's topic, actually, I would like to present on pediatric non-accidental injuries. Myself, Dr. Ashish Salim, working at Trivandrum and PRS Hospital. So these are few news cuttings. Like you can see, as India is a country which is rich in culture and diversity, with over 1.3 million people, it is the second most populous country in the world. And while the population is a source of strength, it also causes some problems like child abuse. So child abuse is a pervasive and serious problem in India right now, and one that continues to grow every year. So what is so important in child abuse? So the WHO defines the child abuse as maltreatment as forms of physical and emotional ill treatment, sexual abuse, neglect, or negligent treatment or commercial exploration that results in actual or potential harm to the child health, survival, development, or dignity in the context of a relationship or responsibility, trust, or power. So the WHO has defined it as non-accidental injuries. It is actually an abuse purposefully inflicted on a child. But what is the scenario? Almost half of the child abuse are missed in an acute setting, that is in the emergency department, due to the failure of treating clinician or to detect or appreciate the features suspicious of non-accidental injuries. And the alarming factor is that only 3% of the child sexual abuse cases are being reported in police. So I would like to emphasize on the magnitude of this issue. This is actually data collected from the national crime reports. So the cases of crimes against children were reported in the country in 2021 was around 150,000. In 2020, it was actually 128,000. And there is a increase in 16.2% during the 2021 over 2020. So this is actually has been continuing since a long years. Like the percentage has been increasing in each year in child abuse, kidnapping, POCSO Act, everywhere. The most of the patient who has been reported is actually kidnapping and abduction. And we can see that only kidnapping and abduction are mostly being reported to the police nowadays. The cases under POCSO Act comes under around 36% of all these reported cases. So these are also actually a statistics from the NCBR. So you can see in overall Asian countries, India actually head of all these other countries, including China. This is a grave statistics and one that demands our attention right now. So what we should be taking care, for whom we will be looking for the NIAs in patients who are coming to the emergency department. The caregivers who has a low educational level, any history of substance abuse, any parents having domestic violences history, the caregiver himself or himself being abused as a child, all are suspected to be having children with NIA or caregivers who have taken care of such children. In the emergency medicine perspective, the ED miss rate of acute MA, this was a study has been done long back in 2007. The ED miss rate of acute MA is just 2% in the best case scenarios. The miss rate of pulmonary embolism is around 5%, whereas the NA, non-accidental injuries, estimated ED miss rate is around 30%. And the consequences are very high in non-accidental injuries. The mortality rate comes around 10% or even higher. So 30% of the cases that we actually see in emergency department are being missed out, and the mortality is even higher. And it was in a 2007 statistics. I believe that this statistics right now have been more alarming. So what are the tips to pick? Any peculiar behavior on the child's part, such as following, should not be overlooked. The frozen watchfulness of a child, an unusual reluctance to undress, a fear of physical contact, a lack of normal behavior towards a carer, any marked changes in emotional state. All these actually are tips that we can find in child abuse patients. So this is actually taken from the Royal College Emergency Medicine. When we should be considering non-accidental injuries, the story is vague. When the story is vague and the details are lacking, the story changes each time when the caregivers tell. There is a delay in seeking the medical help. The history is not compatible with the injury. The history is not compatible with child's developmental age. And there are multiple previous attendants with injuries or illness in the emergency department or in the hospital. There is history of violence or domestic abuse in the family, and the child's interaction with carers appears to be abnormal. All this has to be in our minds to be more suspicious of any patients coming to non-accidental injury, so that we can pick those cases. So these are also from the NHS guidelines. So every patient coming to the emergency department, we have to look, listen, and observe. We have to take a proper history. Any history that is given should be recorded. The report of maltreatment, disclosure from a child or young person or third party. Child's appearance or behavior has to be noted. Any symptoms has to be noted. Physical signs, any results of any investigation like imaging. Interaction between the parent or carer with the child has to be also mentioned. All the history, all the symptoms had to be seek an explanation. So if you see any implausible, inadequate, or inconsistent history with the child, or the child's presentation, normal activities, medical condition, if any of it exists, or age or developmental age, we have to make explanation for that. Between the parents or carers, there are discrepancies. We have to see for any explanation. And any cultural practices that has been actually non-explainable has to be also seek for an explanation from the parents. We have to record all these findings in our case files, and this should be of our concerns. We'll look into it like we'll divide it into consider, suspect, and exclude. Consider are those diagnoses for NAA that we have a DD, NAS and DD. If an alerting feature prompts you to consider maltreatment, look for other alerting features of maltreatment in the child or young person's history, presentation, or the carer's interactions with the past. And do one more of the following. Discuss your concerns with a more experienced colleague or a pediatrician. Gather collateral information from other agencies like SNAP. Ensure review of the child or young person at a date appropriate to the concern, looking out for repeated presentation of this or any other alerting features. If you suspect, that is like one of your DD, or like if you suspect to be having an NAA, if an alerting feature or considering child maltreatment prompts you to suspect child maltreatment, refer the child or young person to the children's social care, or again, the scan has to be informed or SCAPE has to be informed. Other patients we can exclude, and all these details has to be documented. So this child abuse just doesn't include only the physical abuse. It includes neglect, physical abuse, sexual abuse, mental abuse, psychological abuse, and even now online abuses. So relating to physical abuse, that we are actually more prone for, and we are actually have the more privilege to get detected. Any part can be affected, commonly skin, skeleton, head and abdomen. We should be evaluating and treat the prior to the initiating legal workup. Careful history is the game changer. Any inconsistencies, discrepancies, delay, changing history has to be noted down. So what can be the risk factors? In infants and younger age, there are more prone for NAA, multiple fractures of different ages, rib fracture that is very uncommon in pediatric group, metaphyseal fractures, humerus fracture in child less than 1.5 years, femoral fracture in non-ambulatory child, inconsistent history, all these counts. So these are the chief complaints that usually be happening. Chief complaints that usually be happening, like 6 Bs we can remember: bruises, breaks like fractures, bones with head injuries, burns, bites, and baby blues, that is baby crying out to be cyanosed. So this is an X-ray of a patient, of a 4-year-old child who came to the emergency department, who had erythema over his left elbow, and the X-ray has been taken. You can see a bucket handle fracture, which is a classic sign of NAA. It usually happens due to violent jerking or shaking of the child's limb. It is highly suggestive of NAA. Any such X-ray should be alarming to recognize NAA in the emergency department. Another patient, 4-month-old fever, came with 101 degree Fahrenheit temperature and cough and congestion. Well appearing, and had crackles on the right base. He had a mild 1 millimeter bruise in the right rib cage. So mostly what we will be thinking of, any bronchiolitis or LRTA, right? So this patient actually had a skeletal survey later. The patient had multiple partial healed posterior fractures that can be seen over here, multiple posterior fractures, and the posterior medial rib are also had a compression fracture. So 95% predictive value has got in this case for non-accidental injury, especially in child with age less than 3 years. This usually happens due to the parent or caregiver or any other adult squeezing the chest, which causes these type of fractures in the chest bones. Again, this is one more usual finding that we can get in non-accidental injuries, which is hemorrhagic spots in the retina when we are seeing the fundoscope. This is a more strictening case of abusive head traumas. The most common cause of traumatic head death in infancy and early childhood, usually named as shaken baby syndrome, which includes the triad of subdural hematoma, retinal hemorrhage, and cerebral edema. The fundus examination can be seen with sparse retinal hemorrhage, usually as isolated to the posterior pole. So even in patients, like we'll be like so reluctant to take CT brain in pediatric patients, just having any mild form of bruises or something. So even such patients, we can actually rule out or ruling any NAA with use of fundoscope or ophthalmoscope and see for any retinal hemorrhages. Coming to abdominal trauma, which is the second most common cause of death in abused children, we can see for any hepatic transaminases and abdominal CT in the suspected cases. So particularly fracture, the evidence is strongest for the age, any patient having fracture with age less than 12 months, or non-ambulatory patient status with fractures, a suspicious history, or the presence of any additional injuries. So any fracture, we should be looking for the child's age and milestones. If the milestones actually doesn't counterstone to the injury, we should be having a suspicious for NAA. And also the mechanism of injury, what the mother says or what the parent or caregiver gives to translate with the injury. If it is not substantiated, we should be looking for NAA. And other injuries or red flags for abuse has to be seen. The fracture pattern, if it fits to the mechanism of injury or not, and other differential diagnosis also has to be considered. So again, fractures, in the younger the age, the stronger the suspicion should be, because the paucity in the limb movements and inability to bear weight incidentally dictated fractures, rib fractures in the absence of severe trauma should be raising a suspicion for non-accidental injury. The fracture having various stages of healing is the most common sign for patients who haven't had a frequent hospital visit, but the patient had recent various stages of healing should be giving a suspicion for NAS. So here are few fracture patterns that we can see. There are different fracture patterns like transverse fractures, spiral fractures, buccal handle fracture. Then the classic metaphyseal lesions, the communautator fracture, all can be present. So the transverse fracture, usually the mechanism, biomechanics is actually bending force with a 90-degree to the bone. If the parent says like if the leg is caught between two steps or some rails, it is fine. Or the other, like any other explanation actually should be giving you suspicion for NA. Any spiral fractures should be usually caused by torsion. Usually can be seen in leg fold underneath the body. Any buccal handle fracture, which can be due to compressive axial load. If it is the carer gives a history of fall on outstretched hand, it should be comprehensive. Then again, classic metaphyseal lesions, usually caused by torsion and traction, which usually occurs in pulling and twisting of the limbs. And communautator fracture with high energy impact, usually due to motor vehicle collisions. Also, like if the history doesn't make out the mechanism of injury, you should be suspicious for non-accidental injuries. So coming out from fractures and physical injuries, we go for bruising, which is most common and but overlooked one in emergency department. So we should be differentiating it as from the accidental or abusive mechanisms of bruising. Every bruising, the site, size, symmetry, the numbers, clustering, patterns, everything has to be noted down. We should be also looking for other differentials like bone mill band, like coagulopathies, autoimmune disorders, connective tissue disorders, all should be considered before looking out for child abuse or non-accidental injuries. So these are few patterns of bruises that we actually see, like belt buckle injuries, belt injuries, then hanger injuries, fly swatter injuries, any spatula or hand knuckles injuries. All these patterns has to be seen and looked for if you suspect any non-accidental injuries in pediatric patients. There is a 2.5-year-old boy with clinical bronchiolitis and increased work of breathing. The features of easy bruising were seen. Faint bruising is noted on the right hand and left shin. So what all tests we will be ordering for? Usually it was a bronchiolitis with a viral fever. You suspect a hemorrhagic fever. You would have sent for all the fever workup and imaging has been done. Even a chest X-ray also would have been taken. So the bronchiolitic workup with coagulation was checked. It came to be normal, and the patient actually was released home and was planning to review in the OPD. But the patient died from non-accidental injury prior to the follow-up. And the autopsy finding was having old and new fractures on the autopsy. So such cases can appear in our emergency department also. So while breaking down the case, what we could have actually missed? Were there any indications for more evaluation for such patients? So the clinical patterns you must recognize. Any retrospective red flags of bruising, like bruising in a non-ambulatory patient, any age under 4 months, any bruising to the hand, poor history offered, all this has to be looked for when you see for any bruising. And any poor history offered from the caregivers also has to be looked for. So there is a 10-4 rule that can be considered in bruising for abuse patients. What is the 10-4 rule? The T stands for the torso, E for ears, and N for neck, and 4, that is any age less than 4 years. In the torso, it actually includes the abdomen, trunk, upper thigh, even shoulder has to be included. Any bruises seen less than 4 years with any of these parts has to be considered. If there is no confirmed accidental accounting for bruises, then you should be concerned for abuse. Also, any bruise seen in a child less than 4 months old should be considered. That should be in any part of the body, should be considered for NAA if you don't have any other accidental accounting for bruising. This has got a sensitivity of 97% and specificity of around 84%. So another form of abuse is actually neglect. Neglect can cause physical injuries, mental traumas, everything. This is the most common form, failing to meet the child's basic needs like provision of food, shelter, clothing, healthcare, education, supervision, or nurturance. There are different types of neglect coexist. The multiple risk factors includes poverty, substance abuse, mental health of caregivers all substantiate for the neglect. Coming to child sexual abuse. So usually the ED visit may be due to a large spectrum of issues like anogenital bleeding, vaginal or urethral discharge, dysuria, even a urinary tract infection, with sexualized behaviors or suicidality, recent disclosure of sexual abuse without any specific physical symptoms. Examine the child should conform to the medical legal practices in the institute or depending on the place. These are the scan teams. The suspected child abuse and neglect teams can be formed in department or hospital to see out any sexual abuse patients or has to examine those patients. Then comes the medical child abuse. Previously, it is termed as Munchausen syndrome by proxy or pediatric condition falsification, and also has been termed as caregiver fabricated illness. Parent or caregiver induces or fabricate illness or injury in such child may be non-responsive to conventional therapies. So we should be also looking for medical child abuses when you are seeing repeated revisits in the emergency department or in OPDs. So when shall we report such abuses? When shall we report all these abuses? When the child discloses there is an abuse, when we discover there is an abuse or we suspect that there is an abuse. So how we report sexual abuses in India? Why should we report sexual abuses in India? So there was an act, Point of Protection of Children from Sexual Offences, that is POCSO Act, that was formed on November 14 on 2012. The two main clauses, main two sections in this act, that I'll read it out. Section 21(1), which requires mandatory reporting of all the cases of child sexual abuse. Hence, the onus is on citizens, that is parents, doctors, and school personnel, to report cases to law enforcement authorities. So it is actually mandatory for the parents, doctors, and school personnel to report all cases to the police or law enforcement authorities. And Section 21(2) provides for greater punishment for persons in charge of any company or institution for failure to report child abuse cases to the police. So it also has a greater punishment that is actually comes up to 1 year punishment for not reporting child abuse cases to the police. Even with this law, it is said to be having only 3% of child sexual abuses has been reported in the police. So the reporting of the offences, the POCSO has defined the methodology of reporting an offense of any person or a child who has apprehension that a sexual offense is likely to be committed or has knowledge that such an offense has been committed can provide the information to special juvenile police unit or your local police. So all these cases, medical legal intimations has to be made. Now coming to how to medical examine of such a child. In case the victim is a girl child, the medical examination shall be conducted by a woman doctor. The medical examination shall be conducted in the presence of a parent of the child or any other person in whom the child reposes trust or confidence. Where, in case the parent of the child or other person referred to cannot be present for any reason during the medical examination of the child, the medical examination shall be conducted in the presence of a woman that shall be nominated by the head of the medical institute. So that everything has to be done by a woman doctor or woman staff if you are examining if the victim is a girl child. And what all diagnosis has to be made? The history collection is very proper. The history collection, all the records has to be noted down. Even when collecting the history, even if it permits, video has to be taken or audio at least has to be taken. The physical examination includes inspection of the genital and anus for scars and burn all over the body, identify the presence of blood or semen on child, any injury to the oral mucosa, breast, thighs should be overlooked, and all the forensic evidence collections include genital swabs, high vaginal swabs, and wash from the penile area. Everything has to be collected in sterile bottles for forensic evidence collection. The laboratory investigations also has to be sent, and also STD screening in sexually abused child has to be sent if it permits. So what are the indications for testing sexually transmitted infections? If there is any presence of genitourinary symptoms or injury, or the assailant has or is at high risk of STIs, or a sibling has an STI, the parents or patient requesting for the test, all has to be done for testing STI. Also, the treatment includes mental health professionals if history involves significant behavioral or emotional concerns. So there are few take-home messages. That is, half of the cases of child abuses are reportedly missed in the acute setting. Detailed documentation is essential. Bruising is one of the most common signs and most readily visible injury resulting from child abuse, but can also be due to normal everyday activities. All suspected cases of child should be reported to child protection authorities as soon as possible. It happened because of the social stigma, like most of the cases have been underreported. The criminal justice system consistently fails to adequately address the needs of children who have experienced a sexual assault. These grief statistics actually should be alarming, and we demand more attention on these child abuses. So these are few references that has been taken. It includes NRPM, not like National Crime Reports, Centenary, Royal College Emergency Medicine, and few articles, and also from IAP. Thank you. Any discussions? Hello.
Hello. Hello.
Hello. Hello.
Oh,
Hello.
Can you hear me?
Yeah. Audible.
Okay. Most of the people, as you said, first fail to recognize this, and even if they do recognize, they fail to report it.
Yes.
Because for us, hitting a child is a common thing in most of the households. So we don't think it as a crime.
Yes.
And our hospitals also lack the social welfare departments. Like in UK and US, they do have some people who can take care of the child for the time being, but we don't have them.
Yes.
So we have some questions. So as an ER physician, what are the treatment rights we have in our hand other than the pediatrician? And what legal implication we have to face as ER physicians?
There has been a stigma that only government hospitals has been taking all the samples, all the patients has been taken to government hospitals for examination. But right now, for treatment purposes, all these patients can be taken to private hospitals and the treatment can be started for them. And even the forensic sampling and other samplings can be taken from private hospitals. And immediately the intimation has to be made to the police. Otherwise, all the treatment particles can be done in any hospitals or by the emergency physician or any doctor. Only thing is that the examination of sexual victims has to be conducted by a female doctor or with the assistance of a parent or a caregiver if the child permits.
Okay, if anyone else has any questions, you may use the QA section or chat box.
It was mentioned even without actually like reporting, is actually like many cases have been underreported. I have seen many more cases like patient who have presented as foreign body with some food particles in the like trachea. So even medical MLC having reported for such patients, and when taken for the bronchoscopy, we could get tons of food particles from the trachea from those patients. And this actually has been made by choking the patient with food particles. So like all sorts of symptoms can be a sign of NA, non-accidental injuries. So we should be having that strong suspicions to detect and to like speak out for this type of cases.
Okay, looks like we don't have any more questions. There's one more. Cases which are under the report are not reported and turned up in ER treated secretively by hospital consultant. Later found to be such instances have happened. Who shall be responsible?
Whoever has been treating those patients, if they suspect, if they have signs of NA, has to report these cases to the local police or pediatric juvenile polices. But if they fail to report such patients, definitely it comes under POCSO Act. That is what I have told 21(1) and 21(2). Such such doctors or any like school professionals, anyone can be punished under POCSO Act till up to 1 year, and even fine can be imposed for them. So this is actually like a step-up call for all the physicians, all the pediatricians, all the EPs who are actually treating those patients. If they are not reporting such cases, even they can be sectioned under POCSO Act.
Okay, it's very common in the year, not just for the NAI, even for regular adult patients also, for domestic violence and all. They do know some doctors in the year, so are in the administration of a big corporate hospitals. They keep requesting you not to raise the MLC and all. But make sure if you don't raise the MLC, you will be responsible, not the person who is asking you not to raise it.
That's
so it's your right and the responsibility.
Even like we have that statistics actually mentioned, with MA we have actually missed those patients only 2%. But in NA we get up to 30% that we have actually missed. In those 10% get actually mortality is actually 10%. So that is the severity, that is the actual fact we have to go through.
Okay, that should be it, Doctor. Thank you very much for choosing such a unique topic and sparing your time to educate us all.
Thank you.
We'll be
Thank you.
closing the meeting. Thank you so much.
Thank you.